today I want to cover metabolic disease. And so this is, you might be asking yourself, well, what is this to me if I'm worried about patients with strokes? But as you may know, some of these disorders may resemble strokes. And so I think it's important to understand what we're looking at. So let's see here. So, the first thought that would come to your mind is probably metabolic disease as in pediatrics. But of course, there are other metabolic insults to the brain that we have to consider. These are poisoning, hypoxia, seizures, and liver disease, just to name a few of these disorders. And these can be thought of as metabolic insults in the sense that a hypoxia is a deficiency of oxygen to the brain. Poisoning, of course, are toxins, and in liver disease, there can be elevated ammonia levels. So again, all variations of a diffuse insult to the brain. But while these are often bilateral and involve the basal ganglia, there are some examples of metabolic disease that manifest as unilateral and stroke-like. And these are specifically MELAS, which we'll talk about, which is a variation of mitochondrial myopathy, seizures, and hypoxia. So where are the basal ganglia and how should we think about them? So we've talked about this in the past, but again, you want to look for the head of the caudate here, adjacent to the frontal horn, and it gives you this medial curve to the lateral border of the frontal horn. So head of the caudate bilaterally. This low attenuation represents the white matter of the internal capsule, anterior limb, posterior limb, genu, and lentiform nucleus, globus pallidus, putamen. And then this triangle here is the thalamus, which abuts the third ventricle, massa intermedia here, or thalamic adhesion. I have to say, one of the nice things for me in preparing this lecture is the awareness that we've covered a lot of these topics already. And so it's nice for me to know you have a base that we all understand. And so I can go forward with some of these more advanced imaging concepts. Here, of course, is the lentiform nucleus illustrated for you in red. This is the globus pallidus in the medial portion of the lentiform nucleus, and then of course the putamen making up the lateral portion of basal ganglia. So I'll start with MELAS. This is a rare disorder, but it's one that you should be aware of. This is an acronym, and so just based on the initials for mitochondrial encephalopathy with lactic acidosis and stroke-like symptoms. It is pretty rare, but you should consider it as a cause of unexplained strokes in young patients. And family history will help you. Metabolic testing can help you. In this example, this patient has, to begin with, an abnormality. You can see there's calcification of the basal ganglia, both the caudate and the lentiform nucleus, which I think nicely illustrates the position of the basal ganglia. And then, of course, you'll notice this low attenuation along the medial aspects of the occipital lobes bilaterally, although somewhat asymmetric. Again, calcified basal ganglia and bilateral infarcts. This is the corresponding MR scan. On the diffusion weighted image, you can see there's some restricted diffusion here in the occipital lobes. This, of course, is artifact from susceptibility effect. Here you see on the T2 weighted scan the difficulty in making that diagnosis because, of course, CSF is also bright on this T2 weighted examination. This illustrates an important finding that we'll consider a little more in following slides. But what you'll see here is this is the area where there was calcification visible on the CT scan, and actually a little bit of T1 shortening here in the thalamus. So this can be a manifestation of a variety of things, but with the thalamic involvement, The two things you should consider here, as we noted, calcification can do this. And usually when we think about large chunks of calcium, we think about signal loss. But when there is molecular calcium, you can get T1 shortening. The other thing to consider here is going to be gadolinium deposition, and I'll show you a case of that. But anyway, these are the features in this case of knee loss. I actually found this paper which showed a similar example in a 9-year-old child, also with the basal ganglia that we noted, and in this case, a larger area of a unilateral occipital lobe involvement. These are two examples from different cases. This is a case of gadolinium deposition. And as you know, particularly the ionic forms of gadolinium can be deposited in the brain and in a characteristic pattern, tends to involve the basal ganglia, and you can also see some in the midbrain. This is a different situation here. Here you see the thalamic involvement. Here you see it just limited to the globus pallidus of the lentiform nucleus. This is typically seen in patients with liver disease or in total parenteral nutrition or TPN. In these cases, the thought is that the portal blood is shunted around the liver due to the cirrhosis, and it is the liver that regulates our uptake of manganese from the gut. And some things, commonly coffee, are relatively high in manganese, some forms of brewer's yeast as well. And so we would have an excess of manganese if not for the liver regulating manganese levels. And so normally it is excreted in the bile. But in cases of cirrhosis, we have elevated serum levels of manganese, and for some reason it gets transported into the globus pallidus. So be aware of this finding, but there can be some confusion with gadolinium deposition. Of course, in these cases, you can always find out if they had multiple GAD injections, and in these cases, liver testing usually will demonstrate the problem, or there'll be a history of TPN. Now, another cause of stroke-like changes in the brain that are not related to ischemia itself is seizures, seizure-related activity. And in these 4 frames, this is an example of an individual who had a seizure. Oftentimes status epilepticus will be part of the history, and you'll see this abnormal signal on the diffusion scan. It looks like restricted diffusion here, a little bit of signal here on the flare scan. Now, this is the same patient 5 months later. You can see that the cortex looks pretty normal here, all right? So this is one of the few causes of reversible restricted diffusion. Venous disease is another one that is a possibility when you see reversible diffusion. So diffusion is not always a one-way street. Restricted diffusion is not always an indication of death of the cells or the neurons. And so this is one of the examples of reversible changes from seizures. This is a patient we had. It was a 45-year-old with status epilepticus, and you can see the whole hemisphere looks abnormal, and particularly the thalamus. And that's been my experience, that the thalamus is often involved in patients with seizures. But you can see how this might be mistaken for ischemia, except that it's not really in a vascular pattern, right? So this would be PCA, this would be MCA, and this, of course, is going to be posterior circulation. So again, look for the adherence of the lesion to vascular territories before suggesting ischemia as the cause. And as I say, these changes are often reversible. Now, it gets a little complicated in cases like this. This patient had prolonged status and had a respiratory arrest, and so was hypoxic. And so these changes you see in the thalami here on the diffusion scan, and there's also abnormal signal in the cortex, specifically here in the motor strip, sort of here we are in the pre-central gyrus, that look restricted. And so the question here is whether we're looking at seizure activity or we're looking at the effects of hypoxia in this case. A similar example is this one. This patient presented with new seizures. Here's the diffusion scan, shows this large area of abnormal signal. 3 months later, the flare scan is abnormal. You can see in a pattern here in the cortex, and the presumption here is the patient had a small stroke which triggered seizures and localized to this area. And so this is the seizure activity, and this is the infarct, all that's left from that initial insult. So my point is that seizures you can be looking at both the changes of the seizures and the cause of the seizures on the same scan. So keep that in mind. Poisoning refers to pathogens that can be ingested, but can also be inhaled or injected. Basal ganglia are often involved, but recognize that these abnormalities are usually bilateral and symmetric. Here's a patient with methanol poisoning. Patient was drinking methanol, and here you see this diffuse area of abnormal attenuation on the CT scan that's roughly symmetric, sparing of the caudate head, relative sparing of the thalamus. Almost all the involvement is around the lentiform nucleus, and there's a little bit of mixed attenuation here. It's not all low attenuation. Here's the MR scan in this patient, again, showing you the edema around the abnormalities here in the lentiform nucleus. Methanol toxicity frequently is hemorrhagic, and so you can also see hemorrhage associated with that particular agent. This patient has not cortical involvement, but diffuse white matter involvement. This was presumed to be heroin leukodystrophy. The patient was using heroin, and this can be a devastating insult with, in a sense, disconnection of many of these neural pathways throughout the white matter. Liver disease is thought to be not a primary problem with the liver, but of course the elevated ammonia levels that can be associated with liver failure. There is a relatively characteristic appearance. This was reported in this paper with this kind of band-like pattern of abnormal restricted diffusion here in the thalamus and posterior limb internal capsule, again with restricted diffusion. So again, when you see these patterns of bilateral symmetric basal ganglia disease, you want to think about liver disease or metabolic disease, in this case, liver disease. But again, another disorder that can also give you bands of abnormal signal. This is usually a pediatric disorder called fucosidosis, which is an inability to handle the sugar fucose. And so this was in a 3-month-old, but again, there's some overlap in these appearances that you should be aware of, but can usually sort these out by history. Both low oxygen levels from respiratory failure or low perfusion from cardiac arrest can result in symmetric basal ganglia abnormalities. This is a case of hypoxia, and you'll notice this blurring of the boundaries of the lentiform nucleus, particularly on this side. I admit this is subtle. This is why I recommend that when you're looking at CT scans to try to pick out the normal basal ganglia in all your cases so that you become familiar with the variable appearance on your particular scanner. This is another pattern of involvement with hypoxia you should be aware of. This is the hippocampus, you can see, which lives along the medial border of the temporal horn. It is asymmetric, even though, again, this is a diffuse insult from hypoxia. And this, I think, was a case of respiratory arrest from oversedation. And here you see that there's restricted diffusion here. This can also see a pattern like this with seizures, but this involvement of the hippocampus is a phenomenon called selective vulnerability. And what that term conveys to us is this idea that while the brain is experiencing the same low perfusion or low oxygen everywhere, it's manifested in focal areas, and the most sensitive portions of the brain are the hippocampal formations and the gray-white junction of the cerebellum. So again, this can give you a stroke-like appearance, but as an effect of hypoxia or seizures. There is also a phenomenon in hypoxia of a late white matter abnormality that can occur, and the patient can have a period of relative lucidity and then a decline in function. And so this is a late effect of hypoxia, this diffuse white matter involvement. If you want to read about this is just one paper, talks about delayed hypoxia leukoencephalopathy syndrome. In this example, it was largely reversible. In this section, I want to talk a little bit more about diffusion-weighted imaging. I introduced some of the concepts to you in a previous talk and some of the physics that underlie the nature of that imaging. Just to review, diffusion-weighted imaging uses the MR scanner to display differences in the movement of the hydrogen nuclei bound in water. The movement reflects the environment that the water lives in. So if you have more structure, you have less diffusion. If you have a more disorganized water, which of course at the extreme is the ventricles themselves, the CSF, the movement reflects exactly where the hydrogen lives. And because the movement is so small, patient motion is a problem, which is why we use very rapid imaging such as echoplanar, which is usually filled with artifacts. But I want to make this point that bright on diffusion is not the same as restricted diffusion. And when I say diffusion, I mean the trace DWI image that we all look at. You should condition yourself to be looking with the ADC map, look at these together. Because the diffusion trace image is a composite of both T2 weighted and diffusion information, and not all lesions that are bright on DWI have restricted diffusion. Here you can see a case. This is a 5-year-old with loss of developmental milestones. Here you see these areas of high signal intensity on the trace image, somewhat asymmetric. Here are the lesions on the ADC map. So this one in particular shows restricted diffusion. Does that mean this is due to infarction? In this case, no. This is an appearance that will persist for a long period of time, that doesn't evolve like infarcts, and this is, in this case, due to mitochondrial myopathy. And so it's thought to be due to some disorder of cell metabolism, this appearance in cases of that disorder. So again, mitochondrial myopathy or Leigh's disease. Now, susceptibility effects also have to be considered because we're using such rapid imaging. So blood products, surgically implanted metal, air, bone-brain interface, these all cause susceptibility artifacts. And these effects are most evident on the echoplanar, somewhat less on gradient echo, somewhat less on fast-spin echo T2. And so in this example, you see on the T2 weighted fast-spin echo image, this high signal intensity here in the putamen bilaterally, and a little bit on the caudate head. This patient had some probably these dentures that have magnets attaching them to the alveolar ridge, but there was a large artifact coming from dental hardware, which distorts the diffusion weighted scan. So even though these were done at the same time, you can see how much more distortion there is in the diffusion scan, but it also allows you to see the abnormal signal here in the putamen in this patient with Creutzfeldt-Jakob disease. Abnormal diffusion is commonly seen in infarcts 1 to 10 days. This is the one that we're familiar with, we've talked about in this course, but I want to highlight the fact that you can see restricted diffusion in some tumors, specifically lymphoma and meningioma. This is thought to be due to these tumors. In the case of lymphoma, these are these blue cell tumors where you have dense cell packing. Meningiomas, we know, are well structured, and that's sort of their nature on histology. And so this is thought to restrict the free movement of water. One other tumor you want to consider in the pediatric group is medulloblastoma. Classically, you can make the diagnosis of medulloblastoma and distinguish it from a pilocytic astrocytoma from its restricted diffusion. Infection, of course, bacterial abscess is the hallmark of this disorder. is restricted diffusion, but note that I'm saying bacterial abscesses. The atypical infections may not have restricted diffusion. Metabolic disease, trauma, shear injury will give you restricted diffusion and acute blood. And I'll show you just some examples of these. Now, there's some lesions that are just bright on the trace image, that these will not show low signal intensity on the ADC map. And these are choroplexus cysts, acute white matter demyelination, and epidermoid tumors. So let's look at some of these. So we'll start with infarcts. Again, these are ones you're familiar with. These are thought to be due to abnormal influx of extracellular water across the cell membrane. And this is what gives rise to cytotoxic edema and is thought to be why agents like steroids do not effectively reduce the swelling in infarcts where the problem is cytotoxic edema. If we look in this case with acute onset of left-sided symptoms, may not be too troubling at first glance, but you'll notice there's an asymmetry here in the appearance of the temporal lobe comparing right with left. If we look at the T1 weighted scan and the flare scan, especially on the flare scan, again, you see this asymmetry. Now, this is a pretty subtle finding. And one other feature you should look for is the so-called Ivy sign of slow flow in the veins or arteries along the surface of the brain, which will tip you off in some cases to the presence of an infarct. But this issue of conspicuity is one you should keep in mind. Is this abnormal? Well, yes, this is abnormal. Is this a finding that we're always going to be pick up and be accurate about? Not really, but it's the same patient, same time frame. The lesion is much more conspicuous on the diffusion weighted study. And you'll see here the involvement of the MCA territory, and notice the involvement of the basal ganglia here, which is expected with a proximal M1 occlusion because the lenticular striate arteries come off of that first portion of the middle cerebral. Here's the MRA in that patient, and here's the right-sided M1 segment, which you see ends right here. So again, diffusion weighted imaging is the kind of the best tool we have for detection of acute infarcts. And on the early scan, we noticed that the infarct can be visible on diffusion, but not visible on flare. Again, we talked about this in a previous session. Just want to show you, this is an example of how metabolism influences infarcts. This is a diffuse insult. Of course, this is hypoxic ischemic encephalopathy in a child, which tends to involve more of the corpus callosum. Here's another child after a difficult delivery with, you see a small area restricted diffusion right at the time of delivery, and here's 3 days later. But again, this diffuse involvement involving the basal ganglia and midbrain. But I wanted to show you this case. This is a case where you can date the time of the infarct based on the combination of the diffusion scan and the flare scan. So this patient who would be expected to have right-sided motor symptoms with this abnormality in the internal capsule, so probably a lacunar infarct involving the basal, internal capsule. And you see that it's high signal intensity here in the diffusion scan. There's no corresponding flare abnormality, which helps date this as being in the first hour or two after the onset of the infarction. So again, use these together to try to date infarcts, because dating can be important in both treatment and diagnosis. Coming back to this notion of tumors with dense cell packing, some of the tumors, peanuts, meningioma, so on, can appear bright on diffusion weighted imaging. So do not mistake these tumors for infarcts. This is the same tumors that often look dense on CT or have high attenuation, and they can look dark on the T2 weighted imaging. So here's a lesion bright on the diffusion scan, dark on the T2 weighted scan, dense on the CT scan, right? So we wouldn't want to think about hemorrhage here, even though that might cross your mind, because usually on an echoplanar scan, the susceptibility effect of blood products would not make it bright in this fashion. So you should think about other disorders, and a tumor with dense cell packing should come to mind. Lymphoma, I think this would be a very reasonable case of lymphoma. This actually proved to be a histiocytoma, so a much more unusual tumor. But again, don't mistake these for infarcts or abscesses just based on the high signal intensity on the diffusion trace image. Here's another tumor, parasagittal, but not extraaxial. You can see there's a little bit of brain along the medial border of the tumor. This is the lesion on the diffusion weighted scan in this cortical location, some edema around it, restricted diffusion. This is a typical appearance. This is lymphoma. So again, not an infarct. This is a tumor with dense cell packing that gives you restricted diffusion. Here's another case. FLAIR scan looks pretty normal. 76-year-old. Here's the diffusion scan. Should we consider the possibility of a hyperacute infarct, as I showed you in the previous case? Well, maybe you should, but you'll also notice that the sagittal sinus looks abnormal here, that we don't see a flow void in it on this slice. And this is what it looks like on the contrast scan. Obviously not an infarct on this basis. Here's the venogram showing you occlusion of the sinus due to this large meningioma at the torcula. So another tumor that is bright on diffusion imaging. Now I will comment, not all meningiomas are bright on diffusion weighted imaging. There are some articles you may have seen or be aware of that suggest that meningiomas with restricted diffusion are more likely to be aggressive or atypical histology. That's not been my experience. I don't think the presence of restricted diffusion really means very much in terms of predicting histology of meningiomas. Here's another lesion. Again, here we see this area restricted diffusion here, medial temporal lobe, enhancement sort of hugging the lateral border of the skull base. And this is just another meningioma. Now, epidermoids and choroid cysts, I'm putting together and lumping together because these lesions can be mistaken for other processes. But the important thing to note is that the diffusion trace scan will be abnormal, but these do not always show low signal intensity on the ADC map. So we're probably seeing in many of these cases some combination of diffusion effect and T2 effects, because again, the trace image includes both. Here's a good example. Here we see this asymmetric perimedullary cistern, widening of the cistern, widening here coming into foramen Luschka of the fourth ventricle. This is what it looks like on the FLAIR scan, but we know that in the posterior fossa, FLAIR imaging can be unreliable because of the either susceptibility effects from the skull base or pulsations, whatever. Oftentimes CSF is not suppressed on FLAIR imaging in the posterior fossa. But when we look at the diffusion weighted scan, you can see that same pattern is abnormal on the diffusion trace imaging. And this is an example of an epidermoid tumor. Here's another lesion. This is actually intraosseous. You can see the expanded medial and lateral borders of the skull. There's loss of bone here. Is this a malignant tumor? Well, you wouldn't think so based on this sort of smooth border here, both anteriorly and posteriorly, but there is an expansile tumor. Here you see the bone loss on the plain film, and this is what it looks like on the FLAIR scan, and this is what it looks like on the diffusion trace image. This is an example of an intraosseous epidermoid, which, as you know, is just a variation of that disorder. Now, in this case, you see this abnormal restricted diffusion in the choroid plexus bilaterally. And if you look on the enhanced portion of the examination, you can see there's just looks like watery on the T1 weighted image. So don't be mistaken by this. And I showed you a case in one of the previous ones where it was unilateral because we had calcification on one side. But again, this is a variation of the appearance of the choroid plexus and is not pathologic. Here we have a lesion that is possibly extraaxial, arising from the paracellular region. It shows low signal intensity here and no enhancement with restricted diffusion, kind of an irregular pattern of, abnormal diffusion and an abnormal pattern of it. This is an epidermoid tumor. So common places for the epidermoid tumors are the paracellular region and CP angle cistern. Blood products are something to consider when we see restricted diffusion. The appearance of blood is variable depending on the age of the blood. It can be bright or dark on diffusion imaging because of the mix of susceptibility effect and diffusion. This case I want to show you, this is a common problem I've seen in my own practice in patients who have had craniotomies. Here you see these patients had a right-sided terional craniotomy. And deep to the craniotomy, it looks like there's some blood products here. Now, again, I want to remind you about another thing we talked about was the evolution of blood products. So this scan was taken right after surgery to gauge residual tumor. But the blood products you can see are already bright on the T1 weighted scan. Does that make sense? Well, it makes sense if you remember that the rules that you may use or be aware of in terms of the evolution of blood products only applies to blood products within the brain substance. So once the blood is in the extraaxial space, all bets are off. So it's not uncommon to see acute blood appear bright on the T1 weighted scan in patients when the blood, as I say, is outside of the parenchyma. Now here on the diffusion scan, it looks dark, but here we are 2 weeks later and now it looks bright. And this is where the trouble begins. Because if these patients have, say, drainage from the wound overlying the craniotomy, they have unexplained fevers, that sort of thing. These can be mistaken for subdural empyemas. And because of the variation on the T1 weighted imaging, actually the T1 scan doesn't help you that much either. So again, be aware of this pitfall, and high signal intensity in the extraaxial space in the immediate postoperative period, most often in my experience, is just due to blood products and not due to infection. Now, this is a good case for us to sort through. Here we see this high signal intensity in the midline, T1 shortening. Here it is on the diffusion scan, and here it is again on the T1 weighted scan. Now those of you that do MR regularly know that in the midline, along the falx, there's frequently on CT scan, it looks like calcium, but this is really not calcification of the falx. This is called ossification of the falx. And in the cases of ossification of the falx, like bone elsewhere, there can be a marrow space inside of the calcifications. And in that marrow space, there will be fatty marrow, which will have T1 shortening. So the question I would ask is this blood or is this fat in this patient who had recent trauma? Who wants to help me with that question? Anybody have an opinion?
I think it's fat.
And why do you think so?
Because I don't see this hemorrhage in cortex. The cortex is normal.
But we know subdurals. We know that subdurals can occur in that location, right? After trauma. So and so the reason I'm showing you this is actually, I think, a fairly confusing case, but I like it because it illustrates an important part of imaging physics. So if I looked at this and this, I completely agree with you. I think this should be ossification of the falx, and you might have a CT scan that would support that. But the reason I'm showing this case is that the fact that if it's bright on the diffusion weighted scan, you can be sure that it is not fat because all diffusion weighted scans are fat suppressed.
Okay.
So again, it just illustrates an important concept of imaging, is that And actually two concepts I want you to be aware. Number one is that with MR imaging, because you have multiple pulse sequences, you cannot really draw a conclusion based on a couple of them and discount information from other of them. So it's like a detective, you have to take all of the information, collect all the evidence first before you reach a conclusion. So I find that very helpful to keep in mind about diffusion weighted imaging, is that because it's fat suppressed, even if your scan does not include a fat suppressed sequence, a chemical fat suppressed sequence, you can use diffusion weighted imaging in those cases to sort through when you're dealing with fat and when you're dealing with hemorrhage. The other place I find diffusion weighted imaging very helpful is when you're looking for metastatic disease in the skull. If you look at your cases carefully, almost all the Mets will be visible on the diffusion weighted scan because we've suppressed the marrow space. Here you can see the fatty marrow in the diploic space here. That all disappears on the diffusion weighted imaging because, again, it is fat suppressed. So again, keep that in mind as you look at your images and use diffusion in that way. It'll help you when the question comes up between blood and fat. Now, this is one that I think most or all of you are familiar with, is the restricted diffusion that you see in bacterial abscesses. But keep in mind, non-bacterial abscesses may not show restricted diffusion, and Mets are a pitfall, is that some Mets can look like abscesses. So we'll start with this one. This was a young man, had his first seizure, comes into the emergency room. His CT scan showed edema. We got an MR scan. It shows this lesion. It looks like vasogenic edema around the lesion. It had rim enhancement. See this right here? And it showed restricted diffusion in the same region that conforms to the border of the enhancement. Notes to some susceptibility artifact over here. This patient went to surgery. This was a abscess. I think that was a staph abscess or strep abscess. Here's another patient. Here you can see the needle biopsy site. This patient had a ring enhancing lesion in the thalamus, some vasogenic edema. This is the diffusion scan. Notice how it conforms to the shape of the rim and looks relatively homogeneous centrally. This is, again, typical appearance of a bacterial abscess. Now, in this case, notice that it has this funny border with this little like septation in it or jog in this, like right here, right? And notice on the diffusion scan that the contents, if I were to draw the border of this lesion of the enhancement, the restricted diffusion exactly matches that. Again, very typical for a brain abscess. So with that in mind, we can sort of expand on that on a case like this. This is a young woman with meningitis, and you can see on the diffusion scan, it looks like there's this layering of material in the dependent portion of the occipital horns. So this is cellular material or pus inside the ventricles. This is not the same as ventriculitis. Personally, I think this is a poor prognostic sign, but this is a manifestation of infection. You'll also see some pus here in the dependent portion of the sylvian fissures. Now, this is a patient who's immunocompromised. So in one of the hospitals I worked at Penn, we had a lot of patients who were immune compromised. So this was something that we always kept in mind in neuroimaging, was the atypical infections. So this patient had this enhancing lesion here. There was another lesion here. You can see the subcortical edema in the posterior frontal lobe. And this was a diffusion scan. So from this, should we conclude that this patient doesn't have infection because we don't see restricted diffusion? And the answer is no, we should not. This is a patient with brain aspergillus. So aspergillus may not have restricted diffusion. So again, restricted diffusion is helpful mainly with bacterial infections. Here's another example. This patient had seizures. You can see there's a lesion here in the midbrain. And here you see a ring enhancing lesion here and another ring enhancing lesion over here. This is a patient with toxoplasmosis, which of course is not uncommon in the untreated HIV population. So all of the atypical infections may not show the same pattern of restricted diffusion that we see with bacterial abscess. And the one thing that I want to comment about toxoplasmosis is in the same patient, the lesions can have variable degrees of restricted diffusion, to the point that they may not all look the same on the diffusion weighted scan, which makes them particularly difficult. Now, the other infection that we deal with every once in a while, at least in the US, usually people who are traveling from somewhere else, is tuberculosis. And TB of the brain is a very important diagnosis because it's frequently misdiagnosed as a tumor or something else. So again, be aware of this pitfall with diffusion imaging. In Armenia, is there any brain infections that you feel that you see with some regularity?
We see very often toxoplasmosis. That's why I answered.
Oh, you do? Okay.
Yeah.
Yeah. Unfortunately, yeah, that's
Also,
probably.
aspergillosis is very often that we see, but especially in lungs, not in brain.
In non-brain, okay. Okay.
Dear Alex, we
Yes.
have toxoplasmosis very often, and the hard cases are coming when the patient doesn't tell you that they have HIV. And actually, we have many cases when we call the relatives and find out who is adequate from them, and they start to tell us the information, because we have many cases with toxoplasmosis, with other kinds of brain damage, with immunocompromised patients. So it's pretty hard.
Tuberculosis.
Yes, tuberculosis as well. It's pretty hard to get the anamnesis because the patient doesn't tell you any information. They don't bring any previous exams. So we need to find out, talking to them, talking to relatives, etc., and finding out the doctors. Yeah, but you showed very interesting cases. Thanks.
Well, I think infection is something that is important to, I would say probably the two most common errors I see in neuroimaging are in the areas of venous disease and infection, because we become used to seeing, some things very often, like at least in my practice, brain tumors and infarcts are extremely common. And so people sort of get lulled into this idea that everything they see is either going to be a tumor or an infarct. And so when these infection cases come along, or venous occlusion cases come along, they tend to get there's a misperception. And I remember actually quite vividly a case when I was at Penn, was a woman that was transferred in with this mass that she was being sent in for resection of what everyone thought was a brain tumor. And her son happened to be an ER doctor from somewhere else. And he was the one that said, he said, my mother was in India like not long ago. Could this be tuberculosis? And that sort of, was like a wake up for all of us. And we pursued that with MR spectroscopy and so on. And indeed did prove to be tuberculosis. So it always stayed with me that this patient, who was basically one day away from open surgery on her brain, when it proved to be infection after all. So again, I don't think we can be reminded too often about these. And I think, Narek, as you mentioned, that oftentimes the history is not there to lead us to the diagnosis, and we have to pursue it.
Yeah. I had a case when patient got 3 courses of chemotherapy because one of the radiologists told that it's a tumor. And they didn't do biopsy, and we did MR, and it was below concentric sclerosis.
Oh, so, really? Wow.
Yeah,
wow.
I'll send you the case. It's a very interesting case.
Yeah, please do. Thank you. Thank you.
Thanks.
I want to mention brain mets and gliomas because we don't usually think about restricted diffusion when we think about neoplasm, but you should, because some mets and some primary tumors can be bright on the diffusion weighted trace image, but you'll notice over time that the degree of restricted diffusion, that is the darkness of the lesion on the ADC map, is usually greater with the infections than with the tumors. For example, here's a rim-enhancing lesion in the temporal lobe and has some restricted diffusion. So if you just take me at my word and you say, oh, Dr. Memorian told me that rim-enhancing lesion with restricted diffusion can be a bacterial abscess, then that would lead you in the wrong direction, because this is a neoplasm, this is a glioblastoma with some restricted diffusion, probably due to necrosis. But coming back to what I mentioned, the restricted diffusion must conform to the boundary of the enhancement. So this area of non-enhancement here should be the alert to you that you may not be dealing with an infection in this case. Here's another case, rim-enhancing lesion. Here's the restricted diffusion. Yes, there is some restricted diffusion, but it doesn't conform to the border of the rim. So when you see this, do not lead with a diagnosis of abscess. You should be thinking of a neoplasm in cases of this type where the pattern of restricted diffusion doesn't match the rim. And if you think about the biology of an abscess, so what happens is the rim is part of the healing process or the response to the abscess, and the center portion should all be pus. So you shouldn't really have some areas that are restricted and some areas that are not in the case of a brain bacterial abscess, but it is not uncommon if you look for it with tumors. And here's another one. This one has one lesion with rim enhancement, one region that's solid, one region that's like a little less rim enhancement, but you'll notice they're all dark on the diffusion weighted scan. So these are just tumors, in various phases of necrosis. This is metastatic disease, but again, not an unusual appearance for that. Now, this case I found particularly troubling. This one, you can see on the FLAIR scan is, we have this round area of a relatively long T2 relaxation time. Looks to me just like an abscess, but this actually turned out to be a metastatic lesion. So I would say once a year, once in 5 years, you're going to see a metastatic lesion that will look a lot like a abscess. And I think that's the nature of the work we do, is that we're not going to be right all the time, but if you're aware of the pitfalls, you're better prepared to deal with them. And in this case, there was a history of a primary tumor, and I think led us to the correct diagnosis. But in some of these cases, you're really not going to know. I mentioned about Creutzfeldt-Jakob disease. This is one of the disorders that gives you abnormal signal on the diffusion scan. This is an unusual pattern of CJD, which gives you this restricted diffusion in a cortical pattern. Again, you can see why it would be very easy to mistake a patient like this for a patient with an infarct. But just not all the CJD cases have thalamic involvement. Some have a pure cortical representation, which looks like ischemia. So just be aware of this. And of course, these patients usually have a fairly striking history that would, if you're aware of the history, then you should be able to make the diagnosis. Trauma is a troublesome one because we, of course, see a lot of trauma, and you'll see a lot of variations of disease in trauma cases. But diffusion is a very powerful way of looking at the extent of injury. Here's a trauma patient with an injury in C of the corpus callosum. Here's restricted diffusion in the splenium of the corpus callosum, which is very typical with trauma cases. But again, this is probably not due to ischemia itself, but some cellular injury. Here's one which I think is interesting. Here's an MVA where you can see there's actually restricted diffusion in the fornix bilaterally. And this, I think, would probably correspond with these patients that you'll see who have short-term memory loss transiently after trauma, and it may be due to some disruption of the function of the fornix. The other piece that will help you with the cases of restricted diffusion in trauma cases, that there's usually associated susceptibility effect. That is, most cases with shear type injuries will also have some blood products. And this helps you to distinguish it from ischemia, which usually doesn't have the same pattern of susceptibility effect in the acute phase. Getting to the end of this list of things that have a restricted diffusion, but again, just I want you to take away the idea that don't treat all patients with restricted diffusion as either infection or ischemia. There are a number of disorders to consider. This is sort of lumped together disorders of sodium, potassium pumps. These is thought to be the cause in venous infarction, venous disease, and seizures. Here you can see this patient has a diffuse abnormality on the diffusion weighted scan, and you can see it is restricted in the ADC map. This patient probably, this is one of these patients where it's difficult to know whether this is seizure activity or hypoxia in a patient who's found down. The patient's also cirrhotic, so you have to consider effect of liver disease as well. So again, don't simply think that you're dealing with ischemic changes in cases like this. You want to go through the history and laboratory values to reach a diagnosis. Acute demyelination is one that's not typically talked about, but occasionally acute demyelinating lesions like this one can show high signal intensity on the diffusion weighted scan. So again, don't assume that you're looking at infection and infarct in all these cases. This topic I want to make you aware of, though, is that not all infarcts have restricted diffusion. And this is particularly troublesome, but I will tell you that it will be easier for you in coming to the correct diagnosis if you keep this in mind. Just because the patient doesn't have restricted diffusion doesn't mean that it's not an infarct. Now, in the literature, almost all the cases occur in this pattern are in the posterior fossa. So I'll show you, this was a patient we had. This was a fellow who was involved in an accident in a warehouse where I think it was a large box fell on his head. And he felt a little, like not long after that, he felt a little nauseated, had some neck pain. They sent him home, but he was driving to work a day or two later. And you can see now he has this mass in his posterior fossa, displacement of the fourth ventricle, low attenuation here, and there's dilatation of the ventricles bilaterally, presumably from the mass effect here with displacement of the ventricle. Here's the enhanced MR scan, kind of an unusual pattern of enhancement. The mass effect is even more evident now, but with the restricted diffusion, with the mass effect on the ventricle and the enhancement. And let's see, here's the diffusion scan taken together. The conclusion at conference was that this patient has a brain tumor, a cerebellar tumor, and they're planning to operate on that basis. But we looked at, it happened to be, it was one of these multi-specialty conferences, and looking at this, you'll notice that there was no choline elevation, and there was a very high lactate peak. And so with the awareness that subacute infarcts can look like tumors in the cerebellum, not all infarctions have restricted diffusion, we advanced the idea that this was not a tumor, this was a subacute infarct. And so we went to angiogram, and this was the angiogram in that patient. You can see that there was no filling of the vertebral artery, and here you see this attenuated V4 and V3 segments in this patient who had a vertebral dissection with occlusion from his trauma, and that proved to be a subacute infarct, which resolved without surgery. So again, be aware that not all cases of infarction have restricted diffusion, but virtually all of those cases you're going to find are in the posterior fossa.